This episode of Pharmacy to Dose, the Critical Care Podcast, is proudly sponsored by Chiesi. Chiesi is a family-owned, research-focused, sustainable pharmaceutical company accredited with both B Corp and a benefit corporation status. Chiesi is making global changes that benefits patients, providers, and healthcare organizations with forward-looking and impactful initiatives. Chiesi appreciates the integral role that clinical pharmacists play in patient care and are proud to support this community. To learn more, visit chiesi.pharmacytodose.com. Again, that's chiesi.pharmacytodose.com. Welcome to Pharmacy to Dose, the Critical Care Podcast, a partner of the ACCP Critical Care PRN. And I'm your host, Nick Peters. And wherever you are and however you are listening, thank you. Now, this is a 2-for-1 episode where we feature a trial of the week discussion before highlighting pharmacists helping literally save lives in an out-of-hospital medical emergency. And the episode starts off with a trial of the week where, of course, I review a landmark article in critical care and emergency medicine history. And today we are highlighting the dexmedetomidine for sepsis in intensive care unit randomized evaluation, aka the DESIRE trial. 2017 JAMA study featuring special guest Jim Miller, ICU pharmacist from Michigan. So we review some of the pharmacokinetic properties of dexmedetomidine and important sedation trials using this agent in mechanically ventilated patients before diving into that trial of the week, discussing trial generalizability, the effect of changing the primary outcome mid-study, anti-inflammatory signals, highlighting Jim's own research into dexmedetomidine for sedation and delirium in general, what agent would he want if he's mechanically ventilated for sedation, and much, much more. Then Michael Liu joins me to go more in-depth on his AJHP article, The Pharmacist Takes the Lead During an In-Flight Medical Emergency. So what happened? Is this the first time he's been involved in a situation like this? What are differences with in-hospital and out-of-hospital emergency response? Tips for others in this scenario, and so much more. If you're traveling to SAEM or you're at AEMP, since it's releasing on the morning of, see you all soon. But this is an awesome episode with two fantastic guests starting right now. And very excited to welcome on our special guest for today's trial of the week, Jim Miller. Now, Jim is a clinical pharmacy specialist in surgical critical care and critical care RPD at the University of Michigan Health, adjunct clinical assistant professor at the University of Michigan College of Pharmacy. You can find him on X at MillerJTM. Jim, welcome. Thanks for joining us. How are you doing today?
Thanks for having me. I'm doing pretty well. Thanks. This is going to be exciting.
It's going to be a lot of fun. You're a Michigan man, so did you survive the Michigan winter? Has spring arose up north for us?
We barely had a Michigan winter this year, so spring has been in effect. My lawn has been having football games on it since February, so we got some repair work to do, but the weather's turning. So
I'll tell you what, I just had my first lawn mow, and it's one of those. I always put it off longer than I need to, and as I'm actively mowing it, I'm like, why did I hurt nobody but myself by doing this? It's it's an every year thing, right?
Yep.
So let's get into our trial of the week, dexmedetomidine for sepsis in the ICU randomized evaluation, the DESIRE trial. So as we set the scene and get into the background just a little bit, from a pharmacokinetic perspective, what advantages should dexmedetomidine provide for us as a sedative?
Well, it's not exactly a short-acting sedative, but it doesn't have any active metabolites that linger around and make patients difficult to wake up when it's time. But it's claimed to fame, right, as a mild sedative. So it seems very well suited for the era that we're in now, where we understand that light or no sedation compared to a deeper level is associated with improved patient outcomes in critically ill patients.
Yeah, that's a really good point of for the times we're at, right? As we're emphasizing light sedation, something that will provide more of a
Yeah.
mild effect is something that would be advantageous. So prior to 2013, right, that's when patient recruitment began in the Desire trial. What were a few of our landmark sedative trials with dexmedetomidine, and what was our kind of general thought? What did they kind of show us as we led into this study here?
Yeah, there are three main trials that come to mind immediately. 2007, the original men's trials, dexmedetomidine versus lorazepam infusion, a relatively small trial. Takeaway, they conclude that using dex is associated with more better delirium-free and coma-free days. We can talk a little bit more about that if you'd like. There is a little bit more bradycardia, which we expect with dex. There's the SEDCOM trial in 2009, bigger trial, dexmed versus midazolam infusion. No differences in sedative efficacy, but dex associated with more bradycardia, less delirium, less infections, which is interesting, I think. And then Prodex in 2012, which published in the same manuscript as MyDex, so be careful. Use caution when you're wading through the data there. There were no differences in sedative efficacy there. In my opinion, not really a difference in safety either. They talk about neurocognitive adverse drug events rather than strictly ICU delirium per se. But an interesting trial. But that's kind of where we're at when we get to this Desire trial.
And so one way you could probably clarify all those three of those is those were all three positive trials for dexmedetomidine, right? All up until this point, when we've been researching, we've found good or positive outcomes when we've compared dexmedetomidine to these other agents, correct?
I think, yes, I think so. At least in terms of safety, right? So we're discovering it's kind of evolving at the same time as the light sedation movement, if you will, and having people wake up earlier and often. And so certainly it seems beneficial, especially compared to the benzodiazepines. Is it a better sedative on the efficacy standpoint? That's still, to be determined at this point. So.
And then you kind of hinted at it. What I'm kind of thinking you're getting at is the lack of the sedative, like the SATs essentially in the SEDCOM trial. And so some of these trials having maybe differences in some of our, what you'd consider standards of care for mechanically ventilated patients now, which kind of can make interpreting some of those studies maybe a little complicated as you're kind of going back in hindsight.
Yeah, I think that's right.
So go like those three trials and even some of the other studies that we didn't talk about, or have we more been researching under the broad umbrella of mechanically ventilated patients?
Well, I think those are the three most robust trials, and those have been kind of under the broad umbrella of an all-comers approach, critically ill patients who require mechanical ventilation for some specified duration of time. There are a whole bunch of small studies that look at procedural sedation with propofol, with dexmedetomidine, but I don't think those really help us answer questions about how to best treat agitation in ICU patients who require mechanical ventilation, whether they have sepsis or not.
And, at this point too, they had kind of had some of these smaller studies showing maybe we have some anti-inflammatory effects with dexmedetomidine. We'll kind of get into, as we go through the trial, we'll get into one of those kind of interesting findings. But let's kind of get into, because it's the perfect lead-in into the Desire trial, the effect of dexmedetomidine on mortality and ventilator-free days in patients requiring mechanical ventilation with sepsis. So published in JAMA, April 2018. It was a Japanese open-label, multi-center, blinded endpoint assessment, randomized clinical trial. So it took place in 8 Japanese ICUs. It enrolled adult ICU patients 20 years or older with sepsis and expected to require mechanical ventilation for at least 24 hours. And they enrolled patients from February 2013 through January 2016. Now, quick reminder, right, started in 2013. Sepsis was defined as the presence of at least 2 or 4 of those SIRS criteria. So either febrile or hypothermic, tachycardic, tachypnea, or leukocytosis. So a couple key exclusion criteria: presence of a few pre-existing disease states, child's PU class B or C liver disease, New York Heart Association class 4 heart failure, drug dependence, presenting with an acute MI, or the attending physician's discretion. So they were enrolled via informed consent and randomized to a dexmedetomidine-based sedation arm or the control arm, which used a sedation, their kind of usual care sedation strategy without dexmedetomidine. They targeted that goal RAS of 0 to -2, and dexmedetomidine was titrated to a max of 0.7 mics per kilo per hour. So the initial co-primary outcome was 28-day mortality and ventilator-free days. The second piece of this composite primary outcome was actually changed from duration of mechanical ventilation to ventilator-free days. So we'll get into that piece in a sec. And the researchers conducted a few subgroup analyses for the elderly, age greater than 65, the Apache 2 scores greater than the median value, meaning the sicker patients in the study, according to the site of infection, and if they had a CV-SOFA subscore of greater than 3. So calculate a sample size 200 to detect 20% difference in 28-day mortality, and they calculated that from the subgroup analysis of sepsis patients in that landmark men's trial. So Jim, highlight anything I missed or anything you want to reiterate, and then let us know what the Desire researchers ultimately found.
Yeah, I think you hit on the main and important points. I read the target RAS range as 0 during the day and -2 at night, which is kind of a unique approach, and certainly might hamstring the nurse who's being asked to be so specific. But primary outcomes, as you said, were mortality at 28 days and eventually changed to ventilator-free days. They found no difference in death at 28 days, about 23 versus 31%, which is not significant. And then no difference also in ventilator-free days, no difference in delirium-free days or coma-free days. I thought one interesting piece was that they found that in patients with an Apache 2 score greater than 23, DEX was associated with lower hospital mortality, but it wasn't clear to me how many patients constituted that subgroup. There was a not significant increase in bradycardia in the DEX group, which, again, not significant, but also not surprising, I think.
This study kind of looking at a composite mortality outcome where a lot of those others were looking at more time and target sedation, time as delirium or coma free. So kind of looking at that more patient specific outcome, did not see a difference. So let's dive in just a little bit. So the first thing that stood out, the control arm received kind of their usual care or non-dexmedetomidine sedation. What does that mean? What was, did the authors describe or go into what their usual care kind of consisted of?
Yeah, I think it's what we commonly understand as the usual care in a lot of these trials. And I think they specify that there's a mix of propofol, midazolam, and analgesia without using dexmedetomidine.
Yeah, they talk a little bit about it in the supplementary appendix there, but yeah, and especially for the time there. Now this is a trial. We highlighted the Japanese trial took place in 8 ICUs in Japan. So thinking about validity and generalizability of these patient populations to the patients that we see in our hospitals, any large differences that might influence how we interpret these findings?
I think there's at least one big difference. Whether or not it influences our ability to extrapolate to North America, I'm not certain. The mean body weight in the two groups is 55 and 58 kilos in a population that's about 2/3 male. Again, would that stop us from extrapolating something, an interesting finding from this? I'm not sure. We certainly have patients like that here, but I don't suspect that would be the mean or the median.
Yeah, in Indiana, those would be the exceptions, not the rule. You'd see 55 and you're like, wait, let me go lay eyeballs on that person. Let me go make sure that that's entered kind of correctly. Now, the other thing we mentioned, the primary outcome or the outcome measure was changed mid-study. So they changed from duration of mechanical ventilation to ventilator-free days. So explain a little bit to us the thought process as to why they probably did this.
Yeah. The goal here is to liberate patients from mechanical ventilation, right? It's a barrier to getting out of the ICU to a lower and less intense level of care. And I always think that if a patient's not getting better in the ICU, they're getting worse because they're exposed to all of the risks, all of the complications of ICU stays. You could, a laundry list, right? UTIs, bloodstream infections, VTEs, pressure ulcers, immobility, all the long-term cognitive difficulties, and the list goes on and on. But so we want to liberate them from the vent, but measuring the amount of time that they spend on the ventilator, while well-intentioned, that can bias study results in favor of interventions that don't work. For instance, if a patient gets put on dexmedetomidine and is extubated 4 days later, his or her duration of mechanical ventilation is 4 days, right? But if the same patient or a well-matched patient gets put on dexmedetomidine and for whatever reason dies after 2 days, that patient's duration of mechanical ventilation is only 2 days, which is numerically better, but obviously not better, right? We don't want patients who die to make the intervention group look better than it is. So a solution to this that's employed in most, if not all, clinical trials that involve an outcome like this is to measure ventilator-free days out of a specific period, like 28 days. And that helps avoid that skewing, which can mislead the reader if we're not careful.
What a great description, because that would essentially just confound the data, right? And bring that in.
Yeah.
So we hinted at, the authors mention, and they go into this in like the protocol and the supplementary materials, that the anti-inflammatory properties or signals that they found with dexmedetomidine was a big reason why they wanted to research it in this population. So the one statistically significant finding essentially in all of their outcomes or all of their research analyses is a reduction in the CRP with the dexmedetomidine treatment arm. So how does this fall in line with other studies that we've seen? How do we kind of interpret this from an anti-inflammatory perspective?
It's a really good question. As a matter of fact, I just saw an abstract this morning from the Vanderbilt delirium group about levels of various inflammatory markers in delirium and coma and how those levels might be predictive. As far as I know, the DESIRE trial is the only one of the three landmarks and the one we're talking about today that looks at inflammatory markers and how dexmed may have some theoretical benefit there. I think this is just fine as a theory. We have to have good theories about things that might work and might not work. If you remember, there was a similar one proposed in the Accurasis trial of early neuromuscular blockade, that cisatracurium might have some anti-inflammatory properties. Lots of things have anti-inflammatory properties in the lab. And so few of them ever turn into effects that have a tangible clinical benefit for patients. So I view it with a very tempered enthusiasm. Could it be true? I suppose, and I hope so. But I think we need to see data that shows that those things help.
Yeah, it's funny you say it happened in the lab, because as you look in like the protocol and the introduction, the first reference is in rats, right? So we're starting from like the animal, and that's obviously how we get this scientific research, but it's that translation from the research side to like the clinical kind of in practice side. So a really good kind of description.
They're all necessary. We just can't skip from one thing to the other.
And I'm not gonna lie, I got burned on those, on the reduction of the inflammatory markers with cisatracurium. That was part of my reason of why I pushed for the higher dose at the time, right? I look like an idiot now. But I was the 37 and a half. I was like, if that's what was studied, we got to use that, right? That's a big thing of what I try to do. Of course, now we have the Rose trial, which of course has kind of made all that go to the wayside. So speaking of kind of taking things away a little bit, did this study really change anything with regards to using dexmedetomidine as a sedative for us? Obviously, if this would have been a positive, that's all we would be seeing. We'd be Precedex everywhere, it'd be going through the vents. But with this findings, with a more neutral trial, did this really change anything for us?
Well, it certainly set the stage for MENS 2, 4 years later, which looked at the same question in a more kind of robust trial design. I did learn that the authors of this desired trial published a handful of post hoc analyses of this study. I don't think any of them can really stand alone and change our understanding about the proper place for dexmedetomidine therapy, but as a hypothesis generating thing, I think that's well and good.
Yeah, I love that you, MENS 2 for the listeners, that's going to be coming right after. We're going to have a little 1-2 dexmedetomidine trials of the week. So, love that. And kind of leading in, one of the reasons that I wanted to ask Jim to come on and highlight this trial was one of the most novel research hypotheses in 2023 that I saw was from your research team in the Journal of Pharmacy Practice, and investigating if a change in sedative administration over time changed the incidence of that delirium. So talk a little bit about where that trial idea and design came from, and a little bit about what that study showed for the listeners.
Yeah, well, my research team is a very generous description of what I was glad to be a part of this group. I love simple studies with narrowly defined questions. And so I really have to give credit to my colleagues, Nick Franz, Nick Farina, the one and only Cesar Alaniz, who was our mentor. They asked what I thought, and I still think is a question that we need to ask more often. We read and we learn about some new practice that we should start, or we should start avoiding an old one, and we try to implement that. But we also want to look back and not just assume that we are seeing the same benefit that somebody else wrote about. Is there a difference in the implementation? Are the patient populations different? Why might one group benefit from an intervention and not another? So we asked the question. We've gone to great lengths to move away from a primary benzodiazepine-based sedation strategy. We did the thing we were supposed to do. Have our patients benefited from it? Because the data all says that they should. Did it happen the way we expected to? And so over 4 years, the amount of benzodiazepine use total in our medical ICU dropped by about 70%, which I think, that's a lot, right?
That's a lot.
And dexmed use more than doubled. But we were unable to show that the actual incidence of delirium dropped in response. As we highlighted in the paper, the pathophysiology of ICU delirium is so complicated. I have a slide somewhere with this proposed theories of pathophysiology of delirium, and it's the messiest. It's awful. So I think it's just wise to expect that single-pronged interventions probably won't carry the day here. It's one of the reasons I think so highly of the ICU liberation study, the ABCDEF bundle, because if anything helps, it'll be a combination of things that make patients feel as normal as possible in very abnormal circumstances and environments. And even that's it's not entirely preventative. We know this. In math, we have the transitive property, right? It tells us that if A equals B and B equals C, then A must equal C. But human anatomy, physiology, pathophysiology, they're so much more complicated than that. And it humbles us, or it really should.
I imagine that pathophysiology slide, I think everybody can picture it. And it's probably because from when you started to now, all you've done is add little pieces, little lines here and there of these like proposed ideas, right? These proposed links. Is it serotonin? Is it cholinergic mediated dopamine? All these different ideas that all have signals.
Right. And I ask learners this all the time. It's like, when you look at that diagram, what hopes do you have that quetiapine, for instance, is going to be the thing that fixes all the problems? It's like it's unlikely.
That's a really good point. That's a good way of looking at it, is look at all of this. And do you think our 25 BID of quetiapine is treating all of this, right? That's a good point. Yeah. So everyone should go definitely look, pull that article, The Association Between Sedative Medication Administration and Delirium Development. in a medical intensive care unit. I mean, you've also, in the same journal, you've looked at the adverse hemodynamic effects of dexmedetomidine in those critically ill elderly adults. So certainly researching dexmedetomidine, and kudos to your group, 70% reduction is tremendous in that long of a sustained reduction in that long of a period of time. So really, really cool job. Glad you shouted out the other co-investigators. So kind of going along with you mentioned the proposal of delirium, and maybe something a little less complicated, but when we're thinking of sedation and our studies that have looked at specific agents, are there does that fall in the same realm as the delirium side as to why we haven't maybe seen an improvement in mortality or any of those other important outcomes in a lot of our modern day studies?
I think so. I think we have seen some important outcomes changed, but it's not just a dexmedetomidine thing. It's a light sedation thing. It's a SAT and SBT thing. It's a mobility thing. Light sedation, I think we understand from many trials now, not just one, is a good thing. And if the patient fits, dexmedetomidine can be the right thing for a lot of patients. The challenge, I think, is figuring out who those folks are who are well suited for this drug. As far as the mortality is concerned, it's so hard to demonstrate that a single intervention in a single trial can do that when patients are so complicated. And the other thing to keep in mind, these are adjunctive therapies. Dexmedetomidine and other sedatives are not the cure for whatever it is that brought the patient to the ICU. These are supportive care things. And so if a single patient can be pathophysiologically complicated, how much more so should we expect that complexity in 500 patients or 5,000 patients in a trial? I'm not saying it's impossible. It's probably not, but it's very difficult. And so I think that we should just use caution in asking dexmedetomidine or really any intervention to bear a weight heavier than it should carry.
As I was kind of preparing for this, looking into a few of them, I kind of came across this idea that those older studies probably took advantage of gaps that we have our awake and breathing, SATs, SBTs, and light sedation, the liberation bundle, and all of those things improve care so much. Does that improvement of care limit those other improvements that we saw? And that was maybe why we saw benefits from those other drugs, because you didn't have everything else optimized. Kind of like if preparing for a couple cardiology trials, and they're finding this in a couple of our MI studies. And it's like, if you've optimized everything else, how much more can it possibly go up? It can. Yeah. It'll just have to be the really good conditions, really good research teams. And that's what we have in a lot of these areas. So curious what would come.
The floor has come up significantly, I think, and there's less juice to squeeze. The Cesar Alanuz, who I mentioned earlier, he wrote an editorial years ago about, I think it was about albumin, but it was talking about epochs of care, right? Things have changed over time. The standards of care have risen so much that it's harder and harder to demonstrate big benefits and outcomes.
It's kind of like the Michael Jordan quote, the ceiling is the floor, right?
Yeah, exactly.
All right, let's end with this. If for whatever reason, Jim Miller has to get put on the ventilator, what sedative are you hoping for? Because all of us, if you see someone, if you're the patient and you can respond, you see someone hanging something you didn't like, all of us are going to be the worst patients because we'll definitely try to stop it. So what drug would you want?
Yeah. I'm going to qualify this, of course. So if I come in with something pretty simple and straightforward to reverse, with a fairly predictable course, and let's say I don't have bradycardia for some reason, I would take dexmedetomidine, sure.
Yeah.
I don't think that the drug is the miracle that we've made it out to be, but I won't deny its value. I'm not a hater, as they say, right? But if I'm really sick, I think I want propofol. Partly because if I choose Dex, I think I'm probably going to get some boluses of propofol in the background anyway to give it a little boost. I think propofol has been kind of underappreciated and underrated in the hopes that Dex would one day convincingly demonstrate and proclaim some superiority at some point. And it just hasn't. Both drugs are fine and they are what they are. and then nothing more or nothing less than that. I just don't find a good reason to tout one over the other when I don't think the data clearly supports that, in my opinion.
This all comes in cycles. I'm waiting for the day where someone comes out that's like, propofol. And I start researching that kind of like it's ketamine, right? The
Now,
older drug coming
it,
back. It's coming. It's going to
it's
happen.
coming anytime. It's just a cycle. It's just a cycle.
I know. I'm telling you, anybody, don't give me any benzo drips because if I'm delirious, I'm going to be a monster in there. So I agree. I'm team propofol if we had to pick, but we'll take any of those non-benzo based sedation strategies. Jim, this was awesome. Thanks for coming on and highlighting a neutral study, but that really kind of set the stage for a lot of these other sedation trials, MENS 2, SPICE 3, that we'll kind of talk about down the road. So listeners, reach out to him at MillerJTM. Jim, we appreciate you. Thanks, man.
Thanks for the invitation and the opportunity, Nick.
This episode of Pharmacy to Dose is proudly sponsored by Chiesi. Providing innovative pharmacologic therapies for over 85 years, Chiesi is committed to supporting the clinical pharmacist community and the patients you serve. To learn more, visit chiesi.pharmacytodose.com. So very lucky to be joined by special guest Michael Liu. Now, Michael is the Assistant Dean of Clinical and Professional Affairs and the Associate Professor of Pharmacy Practice at Touro College of Pharmacy, previously a clinical manager for Yale New Haven Health. Michael, welcome. How are you doing today?
Thank you, Nick. Very good. It's a pleasure to be here.
The pleasure is all mine. And like in the introduction, the listeners and I kind of go through table of contents for pharmacy and medical journals each month, a part of the pre-work for the literature review series. And I read an article in AJHP that instantly stopped me in my tracks titled "Pharmacist Takes the Lead During In-Flight Medical Emergency." And that pharmacist, of course, is our special guest, Michael. So our everyday hero. So glad you could join. So let's set the scene for us. Where are you flying from? Is it a crazy flight? Like, set the atmosphere for what that was like for us.
Sure, Nick. So it was a early riser flight. It left at 4 from LAX, connecting flight, I think, to Detroit. And it was actually pretty packed. It was a pretty full flight, believe it or not, at 4 a.m. in the morning. So there was like no spare seat left. Even the person at the intercom was like, "Oh, this is a full flight. There's no movement available, no change seat of any." So, yep, that was the environment we're in.
Which on the early morning flight, that's the last thing you want to hear is that it's a full flight. So it's a full flight and it's early morning, which I think is even more important because most of the time those flights, right, you're just like, I just want to get there, maybe take a nap, right, finish work, what have you. So at what point in the flight did someone come on the intercom and did they ask for a physician, healthcare provider? But when did that happen?
So that's interesting, Nick. So it was a 6-hour flight, and yeah, with about a little over halfway, probably like at the 4-hour mark, the intercom was saying, out loud, would anyone, either a doctor or a medical personnel, so very specific, doctor or medical personnel, if you have anyone have experience, please come up to the front. We might need your assistance. Shut.
And so headphones were off. You could hear the message, or was it one of those where they interrupted everybody to make sure everyone could hear it?
Yeah, it's the latter. I was actually in the middle watching Despicable Me, because I've a teenager and a 9-year-old, so I like that movie, and I was like a quarter way in, and then all of a sudden I'm like, oh man, yeah.
So how long did you wait? Thinking, because obviously all of us, I think, or many of us have been in that scenario where you hear that and you're like, all right, there's going to be a physician or a nurse come up. How long did you wait in that period?
Yeah, Nick, so I waited about 10 seconds or so. And then there was obvious, I looked up and down the aisle. I was like, okay, well, no one's doing anything. So here I go. And then that was it.
And so did anyone else join you? Because you're coming from mid-year, right? You're flying from mid-year. In your mind, you're probably like, hey, I know on this flight, I'm probably not the only healthcare professional.
Yeah, that's what I was like. Oh, someone must respond, but then no, there was no one. I know there were a few pharmacy interns there, because I thought those big canisters, the typical canister they carry. I guess they were like older in the back or something, and the only person to join me was the person next to me. He was I think he was he worked for a pharmaceutical company. I think he was a rep, though, not a pharmacist, and he was a former EMT.
Okay. So when you approach, you two are getting up, you approach the passenger in distress. What did you do first? Like, kind of set the scene, because I think that would be, I think sometimes that piece alone can be the most intimidating part about responding to something like this.
Nick, your critical background exactly brought up a good point. The first thing is you want to look at the environment, right? Look at everything. And setting the scene, essentially, it was a elderly female patient in distress. Her husband was right next to her, and the first thing was we got a very quick history. And in summary, the patient was drifting in and out of consciousness, and no matter what, she was like about to like not just fall asleep, but like literally lose consciousness. So we had two flight attendants that were just standing there saying, "Hey, if you need anything, please let us know in terms of what to do." And boom.
Did you have a plan where you could say it now because it was successful, but were you kind of winging it as you were walking up, or did you, in your mind, did you kind of have like, all right, here's kind of the ABC I'm gonna do?
Yep. So the ABCs is the first thing that came out of my mind, but everything else was winging it because, depending on what the outcome the ABCs are, we'll have to figure out what they have here, whatnot. Besides the ABC, the next thing I told the flight attendants, like, look, do you have some emergency contact of any sort? Even if they cannot help us in the air or do anything, at least give them a heads up that when we land, we might need some sort of assistance of some sort.
So what supplies does a plane even have? Because when I hear this, my mind goes back to like this old school image of like manipulating a t-shirt hanger to get like IV fluids hanging. So what are they that old school? What like supplies did you actually have access to?
All right. Yeah, you're right. You're actually spot on. The equipment there is, I wouldn't say it's archaic to that degree, but it's pretty close. So they had an oxygen tank, so that was pretty straightforward. That was good with the mask. They had a automated uh, blood pressure cuff, which, by the way, even though it had battery in it, it didn't work. It didn't. I can tell you more about that later. And they had a classic AED, which I say, we don't need AED. This is not a arrhythmia or cardiac arrest, so we're good with that.
It sounds like the cabin crew was pretty helpful for you, or at least they were around as an extra set of hands, is what it sounds like. Because you said they said we're here if you need anything. Did they feel pretty helpful just with assisting to get everything for you guys?
Yes, the great thing about them, and I'm actually very happy with the way they are, is that they're very helpful, like you said, and they're very calm. And the passengers, even around that scene, they were calm also. They weren't like, flipping out, praying, or doing anything crazy or screaming. It was very, very quiet, believe it or not. It was very, very controlled in that sense.
One of my favorite quotes to say when you're going to these emergencies is the first pulse you check is your own, right? And I feel like if you have that area of calm around you, that probably helped you two in this scenario probably feel not as anxious as you could. If everyone was like kind of jumping and things, right? That would increase my anxiety responding to it.
Yep, exactly. And as you know from your critical care experience, like you've seen it in the past that you have to really like be kind of like an orchestra during the moment of madness. You have to look at all the environment and set that calm stage. Otherwise, you're right. It becomes chaotic and you're not helpful for anybody. You're right.
So can you contact anyone in the air, or does all of that wait until the plane actually lands? Like, are you kind of on an island yourself?
Yeah. So the flight attendant did have limited access control. They could contact the what's that called, that tower
Oh, yeah,
that
yeah,
they
yeah. The control tower. Yeah.
the control tower, exactly. They do have control tower direct phone line, believe it or not. I didn't know that. And then they basically said that like they weren't really helpful in the sense of providing us any guidance or anything. They just said like, hey, as soon as you come down, we're gonna have an ambulance and medical personnel ready to go in that sense.
So did you and the former ENT, did you all talk at all? Did you all have a plan, or is it one of those things where you all just kind of worked side by side and you all just kind of worked in tandem like a muscle memory sort of thing?
Yeah, it's the latter. So I asked him like just what while we're assessing her respiratory rate. They didn't have a stethoscope there. I was like, oh, when was the last time you were EMT? It's like, oh, like 15 years ago. So, it's coming back a little bit. So I was like, yeah, I have a clock here. Let's start checking all these vital signs. The vitals were good, fortunately. It was a little bradycardic, but her respiratory rate and the I's and E's, the general is pretty good. The only thing was her consciousness. So we really had to like stimulate her quite moderately, to keep her awake, so to speak.
So you have a critical care training background, but before you kind of shifted into this role and leadership role that you have now. So was this ever something that you wanted to participate in or thought you'd be a part of? Because, sometimes critical care and emergency medicine, sometimes we're into like the high acuity, high stress scenarios. So some people probably are jazzed by this idea, and there's others that probably this gives them crippling anxiety just hearing about it.
Yeah, well, I guess you and I know that we're a bit of an adrenaline junkies. Whenever the need arises, like have something like this happen before on the land, like a few times. Yeah, I remember in supermarkets some collapse. I remember someone like walking down a block in New York City fell and start bleeding like crazy. But they were more straightforward because you want to land, just call 911, make sure they're okay, and then within like probably 5 minutes, someone respond. This, definitely. And again, I waited about 5, 10 seconds, but and then at that point, I was like, you know what? Here comes the adrenaline. I had my coffee and it just walked right up there.
Wow. So this isn't even the first time you've like helped participate in something like this. So what we're hearing is if we're traveling anywhere, we need to get in touch with Michael and make sure he's nearby for all of us as like our safety net then.
Or Nick. How's that? Yeah.
So
or any pharmacist or anybody, yep.
What's the biggest difference when you're helping in the field, right? So we'll say back kind of in the flight. What's the biggest difference when you have non-medically trained bystanders trying to help you compared to our classic inpatient response, right? Where you are a member of a team that is trained for something like this.
Yeah, I think the most important thing is, besides the equipment issue, which you brought up earlier, is that there's a good possibility you have to lead. There is like a 99% certainty, whereas in the field, it's lead physician or some attending or lead resident, something of that nature, or surgeon. When you're on the field, there's a good possibility there's either someone will have little or no medical background, and you kind of have to orient them like, all right, here's one or two things you could do. Here's the task. So you have to kind of function that lead conductor in the orchestra. You do this, you do that, and take charge in a calm and direct but yet confident manner.
Okay, so then how does it end? How does a situation like this end? I've literally landed where nothing happened on the plane and people started clapping. So do you get like an ovation or is it like anticlimactic? What happens as the emergency was kind of treated, you would say, in a sense?
Yes, so Nick, this was not captured in the article, but I'll share this exclusively in this podcast. How's that? So essentially, long story short, the patient eventually, got more conscious. Her skin turned from more paler blue to like more red and fill because we administered the oxygen, cover mask to nose, give her some juice. She was still on that mask until for the last 2 hours of that flight. So here's the thing: when she was stable enough and the plane was about to land, obviously I was like, okay, we should be good. Let's return to our seats. To my seat, I try to watch the remainder of Despicable Me. That's the first thing I did. Didn't finish it, but got another 20 minutes in. All right, so that's the first thing. There was no clapping of any sort. It was very anticlimactic. The flight attendant did ask me where I was seated. I didn't know why, but there's a reason why. They gave me some recognition email later on. But um, once we landed, here's the interesting thing. It was a connecting flight I told you earlier.
Yep.
So we landed, medical, they didn't even came in. She just literally walked outside. They just walk her outside, but they put her on a wheelchair and then they wheel her off. She called her doctor and the medical personnel there, explained the situation, what happened. And the doctor's like, oh, if, based on what you told me and how you are right now, if you feel confident to continue on your journey to Connecticut, which is another 2 hours, you couldn't do so. And this is the kicker here. Guess who was going to Connecticut with her?
No, you were on the same flight with her back.
Yeah, well, her and her husband. So there was
Wow.
no clapping. She was happy. The husband was happy. I'm like, look, don't thank me. Thank the person upstairs. And, again, you got very good people. I hope, and when we got to Connecticut, like we just embraced quickly, and it was a happy ending. We're anticlimactic, but a happy ending.
How long does this whole process take from when you responded to where you go back to your seat? Is this like a half hour?
Yeah, so it took about half an hour to finally get her to some stabilization, and then it probably took another like 15 minutes just to make sure she stays stable. And then at that point, we're like about to start the landing procedure. So that's when back to my seat, having coffee and trying to watch the remainder of the movie.
On your flight home, did you find yourself like peeking over your seat, making sure that, were you like checking on her periodically from a distance?
Yes, yes. So I was about 5 or 6 seats behind her. So I did take peeps periodically just to make sure she's fine. The husband gave me like a thumbs up once or twice, so we're good. What's even more interesting after we came back from Connecticut, someone actually lived in my town was on that flight too. And
It's
it's
a
like, hey, were
small
you
world.
that dude that walked up to the front? On like a Friday evening, we were going to this event, and I was like, yeah, how do you know? He's like, oh, I was on that flight. I was like, oh, okay. The
So
irony of life, isn't it?
it's unbelievable, especially when you said of course she's on your same flight going back home. That's the real kicker there. I agree.
Yeah, so exclusive for your podcast.
Michael, I appreciate you.
Uh,
Now, with your
yeah.
firsthand experience, right? What advice would you give pharmacists or healthcare providers, right, if they find themselves in a similar circumstance to this?
Yeah, Nick, so the more of the lesson is here is you have to lead. You have to do something. Even if you don't feel you're not critical care trained, you're psych trained or oncology trained, you got to do something. It could be something as simple as just call emergency response. It could be something as simple as just calming everyone down, making sure the environment's safe. And here's actually a substance of this lesson. After this article was published in HHP, I had a P3 student that actually read it, but it's not just reading. Okay. She actually told me, it's like, oh, Dr. Liu, I read this article. It was inspiring. Do you know what happened? And I was like, what do you mean what happened? And then she told me that she came out of a restroom one time in a public place, and she saw a guy like holding his head really hard, like holding with his hands, and he actually collapsed on the floor and was having a seizure. And the student's like, oh, I gotta do something. I didn't know what to do. So what I did was I just told the patient to sign call 911. And that's all I did. And I was like, listen, you did something. And she was like, oh, the more I could have like got seizure history from like something like this, his friend or something. I'm like, look, don't worry about this whole status versus whatever. You did the bare minimum right there, and that is the most important. You did something. Otherwise, he could have aspirated and all these other qualities, So do something, lead. I don't care what kind of pharmacist you are, whatever. Do the right thing, do the best you can, and it's better than anything. It could mean the difference between life and death, literally.
Yeah, that's the way the article ends, right? You may be the only healthcare professional available, because I think sometimes we're like, well, we may not know. I don't know all the things to do, but I like what you're saying of taking action, because even though, yes, this might not be something you do all the time, but there are people there, right, who are accountants who have no idea what to do with some of these things, right? So this may be the best we have, and anything you do may make the difference, right? So I love that you highlighted that. I love that you came on to tell this awesome story, share some of your insight. Of course, have a little fun going through the story itself. But Michael, appreciate you, and what an awesome story, our everyday hero on the Pharmacy to Dose podcast. So we appreciate you.
Hey, thank you, Nick. It's been a pleasure here. It's awesome.
Another huge thanks to Jim and Michael, two awesome pharmacists and just human beings in general. Jim is on Twitter at MillerJTM. And if you enjoyed this as much as I did, please let me know at Pharmacy to Dose on all your social medias, pharmacytodose@gmail.com. You want to send me that old school email message, and the reference list, obviously including the 2 featured articles, but as including all the other things that we referenced throughout our discussion. It's going to be in that podcast episode description, right? Clickable link right below those timestamps, as well as on the website pharmacytodose.com. But until next time, I'm Nick Peters. This is Pharmacy to Dose, the Critical Care Podcast. The Critical Care PRN optimizes drug therapy outcomes by promoting excellence and innovation in clinical pharmacy practice, research, and education. For more information, go to critprn.accp.com. Again, that is critprn.accp.com. The podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. Use of the contents and materials on the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users and patients should consult their physician or personal healthcare professional. Users or patients should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guests and should not be interpreted to reflect the official position or policy of ACCP or the Critical Care PRN. ACCP and the Critical Care PRN disclaim any and all liability or responsibility for any direct, indirect, incidental, special, consequential, or any other damages, including without limitation, loss of profits arising out of any use of, reference to, reliance on, or inability to use the podcast, its contents, and materials.